Welcome to Aetcm, the emergency medicine channel. Today we are discussing about a case of abdominal emergency. It's a vascular emergency. Dr. Manna will be giving the details of the case. Can we start?
A 79-year-old male patient was brought to ER in a trolley with a history of abdomen pain since 2 days. On initial 10-second assessment, patient was conscious, oriented and obeying to my comments. On primary survey, his airway was patent. He was talking in one full sentences. There was no gurgling or pooling of secretion. Breathing, his saturation was 100%. Respiratory rate was 22 per minute. And bilateral air entry was equal. No use of accessory muscles were observed. Circulation, his CRT was less than 3 seconds and blood pressure was 160/100 and with a map of 120 and all peripheral pulses were felt equally and bilateral.
What is the importance of mean arterial pressure in emergency?
Mean arterial pressure, depending on that we will be classifying patients. If a patient is coming with sepsis and all, we should keep a map of more than 65. Then in case of any abdominal emergencies and all, we should keep a map of at least 60, like permissive hypertension is mainly. Depending on the map, we will be keeping the target BPs.
More than that, it is a value, but it indicates the perfusion of organs. So each scenario we have different map goals. That's why we need to have a map than a systolic BP or diastolic BP. Okay.
Maybe also the cerebral perfusion pressure. We are always talking in terms of a higher map or lower map, but always remember that cerebral perfusion pressure is depending upon the map. So that is the main important, especially in a patient with head injury. Your most important thing is the cerebral perfusion pressure, which is in turn related to your map. How will you calculate map?
A map is diastolic pressure.
Okay.
Then disability, his Glasgow Coma scale was E4, V5, M6. Pupils were 2 millimeters reactive and GR base was 150. Exposure, hypothermia was prevented by blanket. On adjuncts to primary survey, a blood gas analysis was taken. So it shows a pH.
Why you take a blood gas analysis in a case of high blood pressure? High blood pressure, what is the relationship between a blood gas analysis? What are things because we have pH, we have carbon dioxide level, oxygen levels, bicarbonate levels, electrolytes, creatinine, everything comes in our ABG. But why you prefer an ABG first than any other investigation?
Yeah, we can know the creatinine value.
Okay, one we have our machine has got creatinine value. Okay, that's all. Okay, that's all. But as such in hypertension, why this other investigation? One is potassium, hypokalemia or hyperkalemia. Hypokalemia is commonly seen in primary hypertension. Hyperkalemia is seen in like renal failure and all. Then
Nothing to do with the pH part.
pH is very important.
Acidosis associated with CKD.
Okay, acidosis is associated with CKD. Alkalosis is associated with Cone syndrome, like that, mental fortified access. Okay.
We get a lot of idea in our ABG machine. People should always understand that we have got a lot of parameters in our IBG. That's why we are telling ABG. Routinely, when you say RTG blood gas analysis, it's just the pH, PaCO2, and the bicarbonate and the PO2.
If there is carbon dioxide retention and you have hypertension, what is the differential diagnosis? Obstructive sleep apnea is one of the common conditions where you have respiratory failure associated with the uncontrolled BP. So we should keep all these things in mind and ask for an investigation. Okay.
So in this patient, the pH was 7.401 and bicarb was 25 and PaCO2 was 45. It was a normal blood gas analysis. Potassium was 3.4, lactate was 2 and creatinine was
1.4 is slightly on the lower side and pH is slightly on the higher side. So we have to keep in mind that this patient is high BP is there, hypokalemia is there. It is actually not hypokalemia, towards the lower limit. There is a slight elevation of pH. You can even suspect a hypokalemic hypertension. Okay.
Then as adjuncts, cardiac monitors were connected, the patient was connected to the monitors. Then I asked for an ultrasound abdomen.
What is there in your mind when you are asking for ultrasound abdomen in a patient with hypertension? Why you ask?
You can ask, look for any renal artery stenosis.
Okay, one is renal artery stenosis. You have to ask for a Doppler then ultrasound. Okay.
CKD can be
CKD, you can see the corticomedullary differentiation. You can make. Mass can be rolled out, like suprarenal mass, not renal mass, suprarenal mass. Okay.
Aorta.
Screening of
Okay, aorta screening can be done. Okay. So these are the things you have to look for.
If the patient also had abdominal pain. So these are the two reasons we ask for an ultrasound.
Ultrasound.
Abdominal pain with hypertension.
Simple abdominal pain cannot increase the BP due to appendicitis.
Pain can.
Pain is one of the commonest reasons for acute elevation of BP. Okay.
This patient, we asked for an ultrasound abdomen, which was showing a dilated aorta of more than 6 centimeter infrarenally. That time, since the BP was 160/100, and in case of aortic aneurysm, we will target a BP between 110 to 120 systolic BP. So 10 mg labetalol was given.
Only BP is important, or BP plus heart rate.
Heart rate should be kept less than 8.
You need to control the heart rate, you need to control the BP. Both are very important. So like drugs like nifedipine can be given, but that will increase the heart rate. That will produce more deterioration in the patient. So we need to control the heart rate, we need to control the BP. So you need a drug like that. You have to select a drug like that. What is the ideal drug to be given in emergency room?
Short acting beta blockers and esmolol can be given, sir. Esmolol or labetalol can be given.
Suppose it is not there, you can give a metoprolol also. There is no problem in metoprolol. Esmolol, labetalol, metoprolol, all are good.
How did you manage the pain? That is most important thing in this patient. So once you control the pain itself, maybe the blood pressure will be back to normal. So
in this patient, a paracetamol injection was given.
okay. So paracetamol you give as an IV infusion. So on a background, how will you decide regarding your analysis in emergency room? Somebody is coming with an abdominal pain. So you can have different types of abdominal pain. So for this patient, you selected paracetamol. So what is the usual pattern of selecting an analgesic in emergency room?
Usually we will be starting with a low dose analgesics will be started.
Okay.
In this patient, paracetamol was given. In case of any
How was the response of the patient after paracetamol?
he was better, sir. Actually, this patient was better.
So we have paracetamol.
Then we can go into NSAIDs can be given, but usually it is avoided in case.
NSAID should never be given in a patient who is having hypertension as far as possible, because it has got an action to retain water and sodium. So it is going to worsen the total hypertensive period. Okay. But it may not acutely produce any problem. If suppose the patient is having cardiac failure, it may aggravate. Better to avoid these NSAIDs.
It will worsen the
creatinine.
Okay. Opioids can be given. It will act as an analgesic and anti-inflammatory agent in case of abdominal pain.
Okay. So how will you select the opioid? Which opioid you will select?
This morphine is a mild opioid. Otherwise, you can go for tramadol.
So you have weaker opioids and stronger opioids. You can have from tramadol, you have morphine, you have fentanyl. These are all the options that is available. So depending upon the patient choice, you can select. So before that, you need to know the pain score. Because actually, whenever somebody is coming with pain to an emergency, the most important thing is the pain score. Just like any other vital, you have to ask for the pain score, and you have to decide what type of pain is having, and maybe you have to give an analgesic, selecting a good analgesic, and also you have to type of abdominal pain is also important. When you are dealing with a colicky type of abdominal pain, maybe you need to add some adjuncts also. Smooth muscle relaxant, something you need to add. So the safer option is always to start with paracetamol. Then maybe you can slowly go up. But if the patient is having a severe pain already, but there is no point in this waiting by step, you can directly go and give an opioid, fentanyl or a low dose of fentanyl, and you can give an antiemetic also. That is the most important thing. That you have to remember that whenever you are using an opioid, remember to give your antiemetic. Some antiemetic you need to add on. So that will be the initial plan.
Can you tell the advantages and disadvantages of morphine in this case? Advantages? What are the advantages?
Advantages are it is a good analgesic.
Pain will relieve very fast. Anxiety is very important, because any patient who is having hypertensive crisis, they will be severely anxiety. So you can control. Disadvantages? Respiratory depression. In books it is there, but clinically you may not get it. But what is the most problem?
If it is associated any pancreatic issue, means then it can be.
Okay, hypertension is the most important. This patient, you are suspecting aortic aneurysm with impending rupture, morphine sometimes can be dangerous if the patient develops hypotension. Otherwise, it's a safe drug. Okay.
You have to use it cautiously. That's only thing. Morphine, when we read the textbook, the doses are like 5 mg IV. But you have to give slowly. You can titrate the doses. Maybe you can give 1 to 2 mg slow IV. Then followed by you can titrate and give. We feel that morphine is a very safer drug. Maybe in pulmonary edema patients also, when we classically say that the patient will be a lot of having breathlessness and everything. So at that time, when somebody is asking to give morphine, they will have a fear that okay, whether it will cause respiratory depression. Maybe 1 or 2 mg of morphine, it will be benefit for the patient only. So it will decrease the anxiety. Also, it has got some effect in the pulmonary vasculature. So these all are advantage of morphine. So you can use it very cautiously without much side effects.
After giving labetalol, we assessed the vitals. His heart rate was around 90 per minute and blood pressure was 120/80, and his pain has subsided. So he was symptomatically better. So we went into secondary survey. Ambulance history, there was no allergies. Medication is not on any regular medication. Only past history of hemorrhoids 5 years back was there. Then last meal was taken 4 hours back, and events he was having diffuse abdominal pain since 2 days. It was not it was a diffuse pain, and he was telling that it was radiating to the back. That was the history, and following which he presented to our ER. There was no history.
What are the different ways of presentation of aortic aneurysm?
Aortic aneurysm starting from the heart, if at all.
Abdominal aortic. Here we are discussing abdominal aortic. What are the different ways of presentation?
If it involves the superior mesenteric artery or celiac artery, patient will be having abdominal pain, vomiting, and if it is involving the renal arteries, patient will be having vomiting, flank pain, reduced urine output, rarely hematuria. Patients might be having an aortoenteric fistula. In such cases, melena, hematochezia can be there. Then, if it is it can involve the paraspinal muscles and all, and sometimes patient presents with paraplegia also. The lower interthoracic internal intercostal artery supplies the anterior spinal artery. So patients can come with paraplegia. There can be
you told about anterior spinal artery. What is the clinical finding of anterior spinal artery lesions?
And except the dorsal column sensation, every
patient have paraplegia, patient have pain and temperature loss, except posterior column sensations are spared. So that can occur sometimes.
The patient can have scrotal edema. In the abdomen examination, there can be Cullen sign, Gray Turner sign.
Some patients can have renal failure also because renal arteries are involved. So all these different variety of presentation you can get.
And maybe it can be asymptomatic also. Maybe you are taking an ultrasound for some other reason and you have instantly finding out an abdominal aortic aneurysm. So that is also a possibility. Okay.
But this patient didn't have any associated symptoms. There was no history of any hematuria, melena, hematochezia, no history of any weakness or vomiting. Nothing was there. We went to the head-to-toe examination. There was no pallor rectus, clumping, cyanosis, lymphadenopathy, or edema. All 4 limbs BP were checked, and there was no difference in BP. Ideally, we are looking for a difference in stool BP more than 20, but this patient didn't have anything.
In aortic aneurysm, abdominal aortic aneurysm, what difference you expect?
The blood pressure.
Lower limb blood pressure will be less as compared with the upper limb.
If there is a rupture, you can get a lower blood pressure in the lower limb first. Then later, complete all the pulse and BP will be disappearing. Okay. Otherwise, in a normal person who is having abdominal aortic aneurysm, you may not get any peripheral finding at all in most of the patients. Once it ruptures, you get all these findings.
Maybe in dissection, definitely it will be more prominent that one limb you will get the blood pressure, one limb you will not be getting the blood pressure, all the pulse variation, everything. Dissection will be more prone for that. Okay.
Then we went to the systemic examination, per abdominal examination, on inspection per abdomen was distended. There was no Gray Turner sign, there was no Cullen sign, there was no scrotal edema or anything, no visible pulsation. And palpation.
So ideally you should palpate whenever somebody is here seeing an abdominal aortic aneurysm. Already you have done an ultrasound. I feel that you should not, you should be very gentle to the abdomen.
Can avoid that
Avoid.
examination
Already-
because already ultrasound is done.
Maybe the classical teaching you need to go ahead with palpation, but already you have seen something, there is an aneurysm. You need not give an over pressure to that, and there is a chance that it will get ruptured. It is better not to do palpation.
Then other system, a cardiovascular system examination. There was no raised JVP. Precordium appeared normal, and S1, S2 was heard. There was no S3. There was no AR murmurs. Nothing. And central nervous system examination. There was no focal neurological deficits, and respiratory system examination. Inspection, trachea appeared central, and there was no use of axillary muscles of respiration. And bilateral air entry was equal.
So to summarize, you have an elderly gentleman who has come with an abdominal pain, maybe 2 days history of abdominal pain, and you have given him some analgesics. He was hemodynamically stable at that person. He has mild hypertension, for you given a labetalol, and after that you done an ultrasound. You find an abdominal aortic aneurysm. So can you just tell me the ultrasound findings a little bit more?
In this patient, the ultrasound report was an infrarenal area aortic aneurysm seen
Okay.
more than 6 centimeter.
Okay.
So and they couldn't find the extent and all. So we thought we will go ahead with the CT because this patient was clinically stable.
Okay.
So he was shifted for a CT abdomen with CT thorax was done. Since his NPO was only 4 hours back, so we went for a plain CT. So.
Basically, you went ahead with the plain CT. Okay. Ideally, it will be a CT aortogram. And somebody is saying it will be a CT aortogram will be ideal. But maybe in an emergency situation, 4 hours NPO is good enough. I don't think there should not be any contraindication for that. CT aortogram itself, you can go ahead and do. Okay. So, what is the CT findings?
CT finding, it was showing an infrarenal aortic aneurysm, almost 9.6 centimeter aneurysm was there with impending. It was showing a ruptured
Contained rupture. Okay.
Was there. So that was the initial professional diagnosis of the CT, and the patient came from the CT room. That time a patient had profuse sweating and all, and patient was looking very anxious. So we rechecked his vitals, but his heart rate was around 70, sir. It's not tachycardic, but blood pressure was only 80/45.
In that situation, what you do as an emergency doctor?
In this patient, since we already know it is a case of a ruptured aortic aneurysm, we thought we will monitor the patient GCS and BP, and we maintain him in a permissive hypertension.
So you don't want to increase the BP to a normal level. That is very important.
So the most important thing, remember that 2 large bore IV access have to be placed. 2 large bore IV access, and ideally, if time permits, maybe you can go ahead with the central venous access for better fluid management. Not fluid management, you need to start your inotropes, maybe blood products. Maybe initial fluid management, 2 large bore IV cannula is more than enough. And maybe better BP monitoring, everything you need, maybe an arterial and all those things. Maybe as an emergency perspective, 2 large bore IV access will be sufficient. Maybe a critical care, more into critical care, maybe this patient is planned to getting shifted to the OR. Maybe you can definitely think in terms of putting a central line and an arterial line. Okay. Do you want to intubate this patient? That's my question.
The patient is having any retching or any severe pain, it
Okay.
is better to intubate because struggling itself can cause the rupture of the aorta.
Okay, so
An electric intubation sometimes
So you have to calm down the patient as far as possible.
Reduce
It is best.
the patient is anyway in distress, definitely will go ahead. But with the permissive hypertension, the patient is maintaining, we can wait and see. But definitely, we can hand over to the anesthesia. Definitely, they will be going ahead with an induction and further ahead. So, if you are planning, for example, this patient, you say that, okay, there is no anesthetist available in the hospital. You are the only emergency physician available. Surgeon is telling that you induce the patient, the anesthetist is going to take time. So, how will you plan your RSA?
This patient, usually induction agent, before induction pre-treatment, we can plan for giving analgesics.
Okay.
Low dose analgesics can be given.
Okay. You remember that this patient's BP is 80/40 now.
So, if at all required, low dose analgesic can be given
Okay.
to prevent hypertension. Then,
How will you select your agents? That's my question here. So which agent will be the most safest agent you can choose here?
Aetcm will be the
Atomidate will be among the lot. Atomidate might be the best option. Can you give ketamine?
Ketamine may
In this patient.
Cardiac.
In this patient.
Suddenly it will increase.
When we classically see when you give ketamine, what is the advantage of ketamine? When you have a hypotension, the hypotension will improve. But it has got an adverse effect also, increasing the heart rate. Maybe this patient, an ideal option for an emergency perspective, I think it accommodate will be a safer option. And with other drugs like paralytic agents, which one you can go for, procuronium or succinylcholine, whichever is available, you can choose. So that will be our choice of agents. Then, can you just summarize how will you evaluate a patient coming to emergency room with a suspected abdominal aortic aneurysm? So how will you go with it?
If the patient is asymptomatic, we can go for an ultrasound.
Okay.
If ultrasound is showing features, if either ultrasound will show features of aortic aneurysm or no features of aortic aneurysm, we should look for the extent of aortic aneurysm, whether it is above the abdominal level or if it is extending to the iliac vessel. If the extent is found, that is good enough. Then, otherwise, if the patient is coming with symptoms like abdomen pain, flank pain, vomiting, and all, we will check whether the patient is stable or unstable. If the BP is normal, patient is stable or asymptomatic, we'll go for first. We can go for ultrasound, and if ultrasound is showing features of aneurysm, we can directly go for a CT aortogram. If the patient is unstable, do a ultrasound, diagnose, and if a patient is unstable, it can be directly taken to the
Theatre or the operation theatre. So it all depends upon the patient's presentation, hemodynamics. Just like what we learn in pulmonary embolism management, stable, unstable. Just similarly, hypotension is there or not. Stable, you evaluate. Unstable, you treat. Take to the theatre. That's it. So there is no confusion in this. Okay. So can you, how are aortic aneurysm classified? Abdominal aortic aneurysms?
Abdominal aortic aneurysms are classified into 4.
Okay.
Can be suprarenal, renal, infrarenal, and juxtarenal.
Okay. Okay. So these are the classical classification. Okay.
Can you tell something about hypertensive crisis in different situations? What drug you start? You have a case like this, so you can start levodopa. What are the other drugs which can be used in other hypertensive crises? In emergency.
Hypertensive.
For example, patient is having pulmonary edema with the hypertension. How do you manage?
Pulmonary edema, usually the preferred agent will be a MTG or.
This treatment is pre-pulmonary edema. That you use like any other pulmonary edema, you start airway, you have to take care. BiPAP can be started. Lasix can be given. BP control is another factor. You control BP with your drug. Which drug you prefer? NTG is the most because it reduces BP, dilates the periphery so that heart can pump out blood well. Okay, so there NTG is a good choice. Suppose you have a patient who is having pheochromocytoma, hypertensive crisis, pheochromocytoma. How do you manage?
We should give an alpha blocker and a beta.
Okay, you start an alpha blocker, control the BP, then add beta blocker. But sometimes patient will come with acute presentation,
Flash pulmonary.
There, what you do? Alpha blocker, it will take some time because processing what we have is a tablet. It takes some time.
Alpha plus beta.
Alpha plus beta blocker is again level blocker. It has got a good action, but even then you will have to add an extra alpha blocker, or even we can start NTG also. There is no issue in that. Okay, like that patients can have like a stroke. When somebody is having stroke with high BP, whether to control or not control, that is a question.
If we are planning for if a patient is coming with ischemic stroke, and if we are planning to thrombolize the patient, we will be keeping a target BP of 185 to 110. And if otherwise if we are not planning for thrombolysis, and if it is ischemic stroke, we can keep the systolic BP less than 220 and diastolic BP less than 120. And if it is a hemorrhagic stroke, we should ideally keep the BP in between systolic BP between 140 to 160. Ideally, the BP should be 140-90 in hemorrhage.
Anything less than 160-90 is more acceptable.
Patient with eclampsia, how do you control the BP?
Eclampsia patients usually levodopa is the preferred.
Any other agents?
Magnesium sulfate.
So, there the definitive treatment is always delivery. Then you can give magnesium sulfate and levodopa. Okay, these are the treatment options. Okay. Okay. You're done well. Thank you.